Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today, I'm speaking with the guest editors of the February 2023 issue. That issue is on unified airway disease, and the guest editors are Drs. Devyani Lal, Angela Donaldson, and David Jang. Dr. Lal is professor of otolaryngology and consultant in otolaryngology, head and neck surgery, chair of the Division of Rhinology, dean of education at the Mayo Clinic in Phoenix, Arizona. Dr. Donaldson is assistant professor and vice chair of research in the Department of Otolaryngology, Head and Neck Surgery at the Mayo Clinic in Jacksonville, Florida. And Dr. Jang is associate professor in the Division of Rhinology and Endoscopic Skull-Base Surgery and in the Duke Endoscopic Skull-Base Surgery Program. He is the Rhinology Clinical Research Program, and he is in the Department of Head and Neck Surgery and Communication Sciences at Duke University in Durham, North Carolina. So welcome to Devyani, Angela, and David.
Thank you.
Thank you for having us.
Thank you.
I was thinking about way back when we decided to put this issue together. I'm really glad that actually 3 distinct areas of the country are represented, because I think it is very clear that different airways diseases affect people in the humid south and southeast versus the arid weather in Arizona. So it not only do we have diversity of thought here, but the diversity of the diseases that patients come to see you guys with. So in 2007, Dr. Jack Krause proposed 3 criteria to support the theory of the unified airway. And in 2008, an issue of Otolaryngologic Clinics of North America was devoted to this topic, which was a new concept at the time. Let's fast forward 15 years later, in 2023, Drs. Lal, Donaldson, and Jang have given us a mature and deep dive into the current understanding of the unified airway. I think the issue is terrific, and I actually think it's well worth sharing with your colleagues in allergy and pulmonology. So, we record a podcast for every issue of Otolaryngologic Clinics of North America, and it's actually one of my favorite side gigs. And sometimes these podcasts go article by article or chapter by chapter, and sometimes we go by concept. So I think today let's go by concepts. And of course, we will be alluding back to some of the information that our listeners can find in the issue. So starting with Dr. Lal. Devyani, what is the unified airway and why is it important that we write and talk about it?
So first of all, thank you, Dr. Chandrasekhar. And thank you to the editors at Elsevier, because this is a very important and significant issue of contemporary interest. Since Jack Krause first described this topic, I think there has been a volume of literature supporting the concept of the unified airway. And in a nutshell, what I would propose to the listener is think of the nose, sinus, trachea, and lungs as part of a common respiratory tract. And although there are some differences in anatomy, the vast majority of this respiratory tract is lined by very similar epithelium with a lack of muscles in the nasal respiratory epithelium, etc. But it is part of the same respiratory system. And what we have understood, especially in the last few years, where significant research has gone into the concept, is that disease states in the upper and the lower respiratory epithelium have very similar immunopathological signatures. And this has become much more relevant as type 2 inflammatory conditions like allergic rhinitis and asthma have increased in the population. And although we don't have a good amount of data on chronic rhinosinusitis, we see a trend towards higher prevalence in the population. So about 10 to 40% of the population at some point is suffering from a chronic respiratory condition. And these conditions are often interlinked. And I would encourage the reader to refer to the review and introduction chapter by Dr. Flokins in this edition, which is excellent. Comorbid upper and lower respiratory diseases are often linked through common signatures that can be identified. And these authors go so far as to propose that anyone with allergic rhinitis or sinusitis chronically should be screened for lower airway disease, and reverse. If patient has severe or moderately severe asthma or any asthma, they should be screened for upper respiratory disease. Now, when we say screening, we have to be mindful of how we screen them, and a good history oftentimes suffices. But if history warrants further workup, then we should not hesitate to do so. And what's really interesting, as you will see in the chapters by Professor Hopkins and in the chapter by Dr. Miglani et al., is medical and surgical management of upper respiratory conditions does actually improve control of lower respiratory conditions. And so all these facts that have now been elucidated harken back to Dr. Krause's original propositions. So thank you again, Sujana, and I'll pass the baton back to you.
Thank you. As somebody who lives in the, let's say, lateral extension of that unified airway, the one that's fed by the eustachian tubes in the middle ear, I will say that it is clear to otologists that if the patient can get their upper and lower airways disease managed, their ear outcomes are better, right? So I love the fact that we are no longer siloing every single aspect, but we're understanding the interrelationship. And I think there are, 10 to 40% is enormous numbers, Angela. So Dr. Donaldson, can you talk to us about environmental factors in airway disease and how we counsel patients to minimize these things that are stressing their system?
Yes, I really thought that this was an excellent article. And I think a lot of things it reminds me that I educate patients about it every single day. We talk about environmental factors as a rhinologist when we're trying to focus on the sinus, because everyone thinks that their sinus is the cause of their symptoms, when in fact, sometimes my utilization is a consult with my allergist. And so I say I have this dual role of a partial allergist with my rhinology status. And so we talk about some of the things that are very common. We know about. Our patients say, I'm from the Midwest, so everyone had hay fever when I was growing up. But now we know a lot more. And so we can really use that information to describe how the upper airway is impacted by environmental factors. And these include things such as household dust mites, household pets, pollen, and mold. I will start with mold because I live in Florida, and I swear everyone, or at least my patients all swear that they have mold, and that's the only reason that they are coming to see me. And it's a difficult thing, right? We live in the South, East there. We live in cottages. We live near the beach. It is very difficult to really be able to protect ourselves from mold. Mold likes to live in dark places. It likes to have lack of humidification. And so these things are challenging. What I tell most patients is that essentially you want to look out for it. You want to look at your vents. You want to protect yourself in your home as much as possible. And there are lots of avenues in which we can protect things like our heat and air conditioner and make sure that those things are up to date when it comes to mold. I think one of the interesting things that this particular article highlights is something that I don't think we learned when we were going to in residency training, which is that there's actually a possible role of the microbiome and the airway microbiome and sensitivities to mold. So we don't particularly think about that or knew anything about it, but certainly there's been some suggestion that as a child, you may have more exposure to things that change our microbiome, such as antibiotics. And that, in fact, may make you more sensitive as an adult to mold, which I think is very interesting. And I really encourage our readers to go back to this article because they do a great job in discussing some of the evidence around it, even though it is a bit of a mixed evidence. Everyone knows about household dust mites and how difficult it is to kind of clear those. I always tell patients to focus on the places that you spend the most time, which in reality is probably like our bedroom and living room. And specifically for your bedroom, you want to look at things like your bed linens. Are you cleaning them frequently? Are you using hot water to clean your bed linens? And are you using bleach when appropriate? You also want to look at things as like your vacuum cleaner and making sure that that has a HEPA filter on it in order to optimize the reduction in dust mites within the home, as well as decreasing humidity as much as possible. Again, living in Florida, that means close your doors and your windows, which people pay a lot of money not to be able to do. So that's always a challenge when it comes to my particular patients. I also think that they do a great job talking about, well, what if that doesn't work? Those conservative measures, those small changes in the way we take care of our home. What if that's not enough? And there's actually been some pretty good evidence that shows that patients with severe rhinitis and asthma may actually benefit with some of the usual pharmacotherapy, as well as things like immunotherapy, whether that be sublingual or subcutaneous. And they have shown some reduction in severity for those more, again, severe cases, those with severe rhinitis or asthma. Pollen, we really think about in three different worlds. Again, depending on where you live in the country, this may be a year-long problem. So living in Arizona feels a little bit different than living in, Northeast Florida as it relates to in the springtime, which our spring lasts forever. We have a lot of tree pollen here, and everyone tells me, the oak tree is coming, or we refer to it here as the yellow rain. But this is a real problem. Also, during the summertime, grasses are more prominent, and then ragweed as well in the fall. One of the interesting things that they talk about in the article is how we are finding that the ragweed season has actually extended over the last several years, which I think is important to highlight to patients because they may think that time should really just be a August, September thing, and they shouldn't be having problems anymore because we're outside of what was traditionally, or what I refer to as what the almanac used to tell us about when these seasons would go away. And then I think finally, as it relates to that, household pets. When I first got out of training, I used to be such an advocate of everyone avoid your pets. I spent countless minutes and hours in a consultation trying to get a patient who had a severe sensitivity to their cat and dog to say goodbye to that loving cat and dog. And I think that we all probably have felt this kind of detriment when we have lost the battle. And I've lost a lot of battles on this, but honestly, it probably is by evidence-based the most appropriate and probably the most helpful thing for people to do. I think from a provider and a practical standpoint, it's really educating them about where that actual allergy severity is coming from, i.e. for cats. There's about 8 different pollens or allergens that they found in cats, and that it lives in the saliva as the most common place. And so doing practical things like not taking out the kitty litter if you can, doing small things to try and eliminate those. Also reminding patients, a lot of my patients say, my cat went on vacation for a week, or they went to someone else's house for a couple of days. And so why didn't I feel better? Well, the reality is, it can take several months with the cat not in your physical presence before that dander actually goes away. It's a similar case with dogs, which I have the same problem. There's about 6 different allergens that they found from a dog dander. And again, one of the things many of my patients point out is that they worked really hard to look for a hypoallergenic cat or dog. And one of the interesting things that the article showed, and what I think we need to highlight to our patients when they're growing out and they're spending lots of money on these hypoallergenic cats and dogs, is that there really isn't a way to completely have a hypoallergenic pet. That there are immunoglobulins and albumin that are in all these pets that actually are within any type of species that you have that you can still be allergic to, and not just the standard ones that we think about. So there's lots of practical tips that you may not win the battle, but the goal is to educate folks about the things that they can do and make sure that they're making responsible decisions.
Thank you. Yeah, I think the dialogue of, oh, but it's a hypoallergenic pet. Oh, but, I got it to stop sleeping on my bed, or, yeah. And you're right. It's all about education. It's all about what you're willing to put up with. I suppose, right?
My mentor, who is an accomplished allergist at the University of Chicago, Jackie Corey, said, "Don't tell your patients to get rid of the pets. They will get rid of you first." So I've always proposed that. But I was also interested in hearing about from the group, you or everyone else, the impact of urbanization, pollutants, et cetera, because the authors do a really, really good job in pointing out the role of those agents as well in that chapter.
Yeah, I think there's a figure 2 here. They summarize 4 major environmental air pollutants, which is ozone, particulate matter, sulfur dioxide, and nitrogen-based pollutants. And they really talk about the various effects of these pollutants on the unified airway. And it's really very elegant. I remember years and years ago hearing a study that looked at the essentially, we didn't call it unified airway, I think, back then, but essentially the unified airway issues of children in India living about 20 kilometers apart, with one cohort living in a village where there were really no cars. Everyone was in bicycle or walking. There was the pollutants in the air were really the cooking smells, compared to a cohort in a big city with cars and air conditioning and as you said, Angela, lots of antibiotics. And it turns out that the unified airway was healthier in the village, with possibly less medical attention because there was less environmental assault. And I think, we all know about this, right? We all know that we somehow breathe nicer when we're somewhere in the mountains where the air is clean. But I think it's definitely something we're looking at. I know many cities. I know New York is trying to change its fleet of the commuter buses in town, of the regular MTA, to electric. Right, we're doing our best to try to minimize those pollutants. But I agree with you, Devyani. That's a really interesting part of this article. I wanted to move on to talk to David. There's been some research looking at the different outcomes, even in animal studies, when we look at female versus male animals, and in fact, even female versus male cell lines. So we used to always use male sprawly rats, right? And everything was sort of based on that. And then, frankly, all of our medicines were tested in 80 kilogram men. And normally those were 80 kilogram Caucasian men. So as we are maturing in medicine, we are finding that biological sex impacts from a cellular level all the way up to a full person level. So can you talk to us about biological sex and respiratory health?
Yes, absolutely. And this was a really interesting article written by Dr. Lal and her colleagues. And, the article provides a really nice summary of the evidence showing that there are indeed sex-based differences when it comes to the airway across multiple parameters. So that includes disease progression, severity, both subjective and objective, as well as treatment outcomes. Now, the article clearly states that the evidence for sex-based differences is strong. It's stronger in the lower airway. So we see severity of diseases such as asthma, COPD, cystic fibrosis. The severity is greater in women. Now, what we don't know exactly is, why is that? There are possible anatomic factors. Could it be that women have different size of the airways or in lung capacity? But there's also the potential for the influence of female sex hormones, which may, play a role in promoting airway inflammation. So the article really provides a nice summary of that. Now, when it comes to the upper airway or chronic sinusitis, the evidence is not as convincing. For example, we don't know for sure if chronic sinusitis is actually more prevalent in women, as some studies may show. I think the evidence is conflicting in some ways. But what we do have is studies showing that women have worse quality of life from chronic sinusitis, both before and after sinus surgery, even after controlling for disease severity. And again, that could be due to a number of factors. Certainly comorbidities such as migraine, depression have been shown to be more common in women. But overall, I think the main point of the article is that we definitely need a lot more research that needs to be done on sex-based differences. Sujana, you mentioned also based on race and ethnicity. We need to have more research looking at those factors.
Thank you. Yeah, it's something you don't think about, without being prodded, right? You don't think, oh, this woman may end up having a different outcome than the equivalent man. And we don't understand the factors. I think one of the things Dr. Lal and her colleagues do point out is, women may tend to be less compliant. They're kind of busy taking care of maybe the rest of the household, or, their child has to go somewhere and they kind of forget to take their inhaler or their medicine for a few days. So there's a myriad of things that could be addressed, could be affecting this, but the fact that it exists is something we have to be cognizant of. So let's move from like male and female to subtype and diagnosis of unified airway pathology. So Devyani, is there a way for us to think about the unified airway in a more categorical manner, perhaps lending that distinction to improved outcomes?
Absolutely. And thank you for acknowledging my co-authorship on the previous paper. If I could just point out that it's just not symptomatology, but if you look at real outcomes and look at outcomes from cystic fibrosis and asthma, adult women die at a higher rate than men. And yes, there are biological differences, but social determinants also impact health greatly. And so, biological sex and gender roles, this is a vast area of interest for me, but I think it's something that we certainly need to do better in the otolaryngology literature in general. But going back to your rather more straightforward question about subtyping, I think the first part of is to figure out what the patient is coming to see you for and what the diagnosis. And history is really a really good clue in, and whether your symptoms are worsened during the allergy season, whether your cough is exacerbated during the allergy season, et cetera. And having that call out to the link between allergic rhinitis or non-allergic rhinitis and lower respiratory disease and the combination of chronic sinusitis with this as well. And I'd like to call out again the first chapter done by Dr. Hawkins and her colleagues. And that table in figure 1, they really have a good intersection of how mixed rhinitis, allergic and non-allergic rhinitis interplay with lower respiratory pathologists, because you will see that in general, allergic rhinitis has an association with allergic asthma and exercise-induced asthma, and then polyps associated with late onset asthma. And it is fascinating how the interaction of the environment and perhaps our own genetic susceptibilities interact to produce disease states later in life. So in general, I think that once we are past the history, we have to look at what this patient has. So if a patient has allergic rhinitis, you're thinking of concomitant chronic rhinosinusitis or lower respiratory pathology. If they have a history of smoking, then you're thinking of non-type 2 dependent airway pathology, sinusitis, as well as perhaps COPD / bronchitis / bronchiectasis. And in the article that we wrote together with Dr. Miglani and Devekar on subtyping, figures 1 and 2 sort of elucidate how to go about the testing, because obviously not everyone in this healthcare system requires, $1 million workup, but for the people that we can sort of clinically phenotype into different categories, there are testing that is helpful. my co-authors on this chapter, Dr. Miglani is a surgeon like me, and Dr. DeBaker is actually an allergy immunologist. And that's the way we always think about disease subtyping in our practice, which is we look at the upper respiratory part, but we always send it to our allergy immunology colleagues to ensure that they are tested for lower respiratory inflammation, reactive airway disease, and if the history mandates it, workup for immunodeficiency. That's in a nutshell. And I can certainly elaborate on the figures, Sujana, if you want, but I think I would rather have the readers read that excellent chapter, even if I say so myself.
I will warn you guys to get a magnifying glass when you look at these figures, because, or look at them in, when you get the issue in your hand, you can also get access to it online, because there's just a lot of information, but it's really nicely spelled out in terms of a way to think, so that you, like you said, Devyani, you don't do $1 million workup on everybody, but you also don't miss a key portion of a necessary workup on the people who need it. Angela, Dr. Donaldson, we all see patients who present with that cough that won't go away. I've been coughing. And while they're talking to you, every few seconds, you get a over and over again. So can you talk to us about how somebody with an unremitting cough fits into this concept of unified airway?
Absolutely. I think this is a challenge for all of us. And I think it spans all of otolaryngology, pulmonology, as allergy and immunology alike, with the same level of frustration. We really do try and classify this as something of a refractory chronic cough versus an unexplained chronic cough, or that new diagnosis of a cough hypersensitivity. Really, I think that when we talk about the upper airway cough syndrome, which historically was called postnasal drip syndrome, I think that the author, even if I have to say so myself, did a great job talking about the history of this particular syndrome. Very interesting as to the in-depth way in which we explain that an American idea of what a disease is doesn't necessarily translate to other countries, and the adaptation of certain terminology is really challenging. I would say many people, even in the United States, are not really, they're calling it postnasal drip instead of calling it this upper airway cough syndrome. And what we think is going on that's causing this trigger or stimulus is that a person may have postnasal drip, but that drainage in fact causes an irritation or an inflammation of the upper airway structures, which contain these cough receptors. So this drainage stimulates the cough receptors, and then you end up coughing. And so because there's such a hypersensitivity, one would say, then you don't need to physically see mucus going down the back of the nose for patients to have this upper airway cough syndrome or this hypersensitivity due to chronic inflammation. And so again, I would think that the authors did a great job kind of talking about the history of it and explaining it. But I think it also alludes to this really nice table that was put together about how people do decide to treat these folks. Because one of the challenges is that this is a diagnosis of exclusion. So we don't have objective testing that says, yes, you have an upper airway cough syndrome. We essentially have a really great history, and we have potentially some avenues related to the physical exam, but truly this is empiric therapy that works, that allows us to come up with this diagnosis.
And I think particularly we talked about different parts of the United States, but certainly in different countries, there are different ways that this is approached, right?
Absolutely. So, and I think a part of it also has to do with that history, is whether or not the concept is even a believable concept. So European societies, for the most part, feel as though the postnasal drip can't be specifically triggering or causing the cough, because there's certainly large amounts of patients who have postnasal drip but never cough. And I think some of that determination as to what therapy they're going to use, what empiric therapy is necessary, is also based on their belief system of what that actual diagnosis is. So in the United States, we're going to do an antihistamine and a decongestant, but in Europe per se, or in the United Kingdom, they'll only use a intranasal corticosteroid. And then there's a variation of the like. And again, I think a little bit of the attitude related to the diagnosis has potentially implications on the treatments.
Well, can I just ask as an otologist, and maybe I'll ask all three of you, when you're examining these patients, do you see that like posterior commissure inflammation when you look at their larynx, once you've looked at their nose, which I know is the center of your guys' universe, and you've gone back, when these people have the cough, do you see something that looks kind of funny posteriorly, but it's not GERD? Like, what is it that we're looking for as a generalist or a non-rhinologist when we're looking at these people? Maybe I'll start with you, Angela.
Sure. So that's very interesting. And I don't know if we always are doing it right, but I'm looking for, is the nose the cause? Because they're coming into the office with a strong belief that their sinus in their nose is the cause. And so I'm looking for other implications that would make me consider allergic rhinitis or chronic rhinosinusitis as a potential source, because we do know that there is an association between upper airway cough syndrome and allergic rhinitis and CRS. And so number one, I'm ruling those things out. I'm looking at endoscopy, their history to rule those particular things out. And then I'm looking for actual mucus in the nasal pharynx. And if the answer is no to all three, then I'm going to the next level. I'm looking lower down into the airway. I'm looking for inflammation. I'm looking for cobblestoning. I'm looking for edema of the vocal cords that may help me determine, is this a reflux related issue? Is this I eat a lot of dairy and I just have increased mucus production related issue? Or is there another kind of trigger stimulus that is happening? But again, with what everything that we've learned from the article, which people should read, is that just because you don't see it at that one instance does not mean that it does not exist.
Thank you. That's great. David, do you have a different take or an additional take on this?
No, I completely agree with that. I think that the history is really important. I find that when a patient initially presents, whether all that mucus is coming from the nose and the sinuses is really dependent on what the patient tells me. If they feel like it's draining and they're coughing as a result, more often than not, most of the time they will have some kind of sinonasal pathology. So whether I see something on endoscopy or not, I found that I'm the most accurate if I just listen to what they say.
So Osler was right, huh? The patient will always tell you the diagnosis.
Absolutely.
Darn that Osler. I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. You can find all of our issues, articles, and podcasts at www.oto.theclinics.com, and hopefully in your personal and institutional library. And then the podcasts, of course, are wherever you get your podcasts. Today, I'm speaking with the guest editors of the February 2023 issue of Clinics, which is on unified airway disease. I'm speaking with Dr. Devyani Lal, Dr. Angela Donaldson, and Dr. David Jang. So let's continue. So David, let me talk to you, because as I was reading this issue of Clinics, it dawned on me that sometimes otolaryngologists are the ones that initiate a diagnosis of primary immunodeficiency, primarily immunoglobulin deficiency. So can you talk to us about that, about us as sort of like the Sherlock Holmes of this problem?
Sure. Yeah, I think it's important for us as otolaryngologists to be knowledgeable on this subject because in general, immunoglobulin deficiencies are underdiagnosed. And this can lead to increased morbidity and mortality for patients. And it's very possible that these patients will initially present with ENT manifestations, whether that's chronic sinusitis, recurrent acute sinusitis, even otitis media. And I think because of that, the burden is on us as otolaryngologists to have a high index of suspicion and to identify these patients. And so to help with that, this article highlights the most common immunoglobulin deficiencies on table 1, with CVID or common variable immunodeficiency being the most common symptomatic immunoglobulin deficiency. And what I would like to point out is that these patients will most often, again, present with both refractory or recurrent upper and lower airway inflammation. So this includes chronic sinusitis, otitis media in combination with lower airway diseases such as COPD or recurrent pneumonia. But also, it's important to realize that immunoglobulin deficiencies in general are also associated with other infections in the body, the GI tract, skin. And then there's also an association with autoimmune disease and lymphoproliferative disease. So when we see a patient and we're getting the history, looking at all their medical conditions, if they have unified airway disease, in addition to autoimmune conditions, whether it could be Graves' disease or any of those, my suspicion for immunoglobulin deficiency becomes quite high.
So clinically, are these people who have 2 or 3 episodes a year, or are these people who have sort of unremitting upper and lower airway disease? They can't seem to get off the steroids. They can't seem to find a place to live that doesn't trigger. Is that the kind of person phenotypically that we're looking at?
Yeah, that's a great question. I would say that they can present both ways. So there are patients who have these recurrent infections with, periods of time in between where they're doing relatively well. And these are patients who may require multiple courses of antibiotics throughout the year. But there are patients who also have just a chronic, unrelenting form of inflammation. Most of the time in the sinuses, this presents as chronic sinusitis without polyps. We know that a lot of these patients undergo surgery. They may have improvement, but it can certainly lead to refractory disease.
And I see that you put some CT scans in this article, and I wonder if you can I know that this is an auditory podcast, but I wonder if you can use your words to describe what the images might help us with in terms of this diagnosis.
Sure. Yeah. One of the images is probably one that we're all familiar with. And this is the patient with chronic pansinusitis who had conventional sinus surgery, but there's just still persistent mucosal thickening there that's not necessarily polypoid. And there may be a bacterial component there as well. And then another scan shows a patient who actually has an encephalocele, but also has infection on top of that, which certainly puts the patient at risk for meningitis.
So these are not to be taken lightly is what the point of this conversation is, I would say.
That's right. Again, I'll say that it is associated with high morbidity and mortality. So very important to maintain a high index of suspicion.
Thank you. So, it's very hard to talk to 3 rhinologists and not say the word eosinophil. So I've said the word eosinophil. So Dr. Lal, Devyani, can we talk about eosinophilic and non-eosinophilic disease and why we have to distinguish these 2 broad categories of airway disease?
Yeah. So first of all, Sujan, I'd just like to clarify that we all lead with our noses. So it's very important to focus on the nose.
Hey, I was just grateful that David mentioned otitis media. Like, really? I am very happy right now.
Yes. So I think that with improved understanding of what drives airway pathology, we've understood that broadly we can categorize the immune pathways into 3 different categories related to the respiratory system. There's type 1 and type 3, which are not associated in general with eosinophil elevation, either in the tissue or in the serum. And there's type 2 inflammatory pathways. And in these individuals, there appears to be eosinophilic inflammation at play in tissue and in certain instances, such as eosinophilic granulomatosis with polyangiitis, even in the serum. So broadly, I think if you start thinking of them as eosinophilic, as type 2, and the non-eosinophilic as non-type 2, I think that helps us frame a diagnostic workup and also the therapeutics. In general, type 2 inflammatory processes are more responsive to corticosteroid and targeted treatment towards associated type 2 inflammatory biomarkers. You brought up, we can talk about urinary LTE4 levels, which oftentimes show leukotriene-associated disease, as I'd like to call them now, as opposed to aspirin-exacerbated or non-eosinophilic, NSAID-exacerbated respiratory disease, because I really think that there is some association of leukotriene-associated inflammation in these patients. And I'm sure you'll talk about that in general. So I think it's important both for diagnostic and therapeutic purposes. And if we can start identifying those, we can perhaps perform more targeted diagnostics as well as therapeutics and improve outcomes for our patients. In my practice, and maybe perhaps the three of you also share that, type 2 inflammatory pathways that are associated with eosinophils are getting better outcomes in my hands, because with complete ethmoidectomy, proper frontal sunisotomy, large hole surgeries, and putting these patients long-term on nasal steroid irrigations, they appear to have better control of the disease. And in certain subtypes of eosinophilic disease, such as aspirin-exacerbated respiratory disease, targeting leukotriene pathways of inflammation or aspirin desensitization also improves the outcomes, both in search of in terms of recurrence of polyps as well as control of asthma. Likewise, I think eosinophilic granulomatosis with polyangiitis, or EGP, or formerly known as Churg-Strauss vasculitis, has much improved outcomes now with the use of biologics. We have mepolizumab, a biological drug, specifically improved, and others are also under trial for this condition. However, in my opinion, non-eosinophilic disease, which are reflective of type 1 or type 17 pathways. Type 17 is also another name for type 3 types of immune systems. Those are the orphan diseases. And these are the patients that are the most recalcitrant in my practice, because these patients oftentimes are former smokers, some of them going back to the environmental impact, smoking, a big one. And as with the rise of smoking in young women, I think we have to be worried about what will happen to them in 40 years. Secondly, you can see that environmental factors like serving in Iraq or Afghanistan, I see some of those veterans, and they have a very mixed bag of inflammatory markers in there. So definitely there are very different outcomes for these patients. And these patients tend not to do very well with oral steroids or even nasal steroids. And oftentimes we struggle. So it's important to subtype them adequately. I think that the best way that I have found that is practicable is to work with your pathologist and ask them to work with you in telling you, no, this tissue is not cancer, because we already know that. And no, this tissue doesn't have fungus. Well, fungus is everywhere. If it's there or not, it's a matter of chance. But tell us if there are eosinophils in there that are greater than 10 or less than 10, because that marker can give your patients the benefit of a targeted categorization and targeted therapeutics, and doesn't require 20-point standardized pathology report. But that may be very critical to the outcomes, and especially understanding that we now have biologics that target type 2 inflammation. Putting patients that don't have type 2 inflammation on biologics doesn't make sense. It's an expensive and potentially dangerous treatment. So that would be my supposition. I think that when we look at eosinophilic inflammation, we look at comorbid asthma as a factor. And if we look at patients that have chronic rhinosinusitis with polyps, you'll see that about up to 30% of them will have asthma if you screen them. And a good screening question we found is, do you have coughing? Upper airway respiratory hyperreactivity can often clue you into the presence of asthma. And there's another study we did where we said, okay, if you have chronic rhinosinusitis and the patient has cough, you may have asthma. There's a high sensitivity to that, not high specificity, but high sensitivity. I would say that that's important. If we look at patients that have severe adult onset asthma, about 80 to 100% of them will have nasal polyps, depending on which study you look at. You look at patients with allergic rhinitis. There are studies that show, that up to 100% can have asthma. I wouldn't say that that's all, true, but it depends on what study population you're investigating and where the study is located. So I really think it's important to categorize into eosinophilic and non-eosinophilic inflammation for purposes of proper treatment. And then if you, in terms of non-eosinophilic disease, there is so little that we understand that it didn't even make it as a distinct chapter in this edition, because that is a big black hole of non-inflammation. And as more and more of our patients go on biologics, for example, that target your immune system, we are seeing these patients in our practice, and we don't know how to manage them. And I think we'll have something to talk about as to what to do in the future, but that is a huge gap. But if you look at certain subcategories of non-type 2 inflammation that are granulomatous in nature, then we do know a few things about granulomatosis with polyangiitis, formerly known as Wegener's disease, and sarcoidosis. I think the important thing for all types of granulomatous diseases, and we talked about EGPA, which is also an eosinophilic disease, is that you have to have a very high degree of suspicion. And there's nothing better than history in finding that. My diagnosis of EGPA come, okay, you've got polyps, you've got asthma. Do you have high eosinophils? A simple CBC is accessible to all. And if you have eosinophilia, oh, wow. Did you, that meets most of the criteria for EGPA. But the other things one can ask for, hey, have you ever had rashes? Because that could be, vasculitis. Have you ever had, neuritis, sensory neural hearing loss? All of those things go with EGPA workup. And certainly if you have noted that they have eosinophilia, they need to see someone to work them up to make sure that this is not in eosinophilia related to neoplastic condition of the bone marrow. So lots of things. Eosinophilic granulomatosis with polyangiitis kills. It affects all three layers of the heart and is a leading cause of heart transplants in the United States. So we can oftentimes be the first physician that is able to diagnose that. And in my practice, I've diagnosed several of them, history, and then a simple CBC.
So when you send polyps, is it a routine that the pathologists across the country will talk about eosinophils or not eosinophils, or is that something special? And do you have to send it in a special way?
No, thank you for that question. So I think that this is just an H&E slide, but not all pathologists read it like so. So we have worked with our pathologists to help us understand whether there's eosinophilic inflammation or not. And then, we send them all tissue. So it isn't just polyp tissue, but it's also ethmoidal tissue that is removed through our microdebrider so that they can look at the maximum number of eosinophils versus minimal, and we'll go with the maximal. And then we also send them the mucus that you suction out, because that does two things. It'll tell you if you have shark-related crystals, eosinophilic aggregates, or fungus in there. And those help us diagnose various other subtypes of sinusitis.
So, David, are you sending in that manner both the mucus and the tissue?
Yes, I will typically send both. The eosinophils are very important, as Dr. Lal said. Certainly, microbiology can be, it can really define medical management as well.
And Dr. Donaldson, Angela, are you doing anything different? Or if you see somebody like in the article on the non-eosinophilic granulomatous diseases, saddle nose deformity, maybe rashes, maybe other things, are you sending urine? Are you doing something different with your index of suspicion?
Sure. I think what I would say about those where I think there's a type 2 processy is ensure that the patient is not on an oral prednisone before they get those things, including your pathology and or your blood testing. Their CBC was differential, which is part of my normal workup. As we know, prednisone can quickly reduce the number of eosinophils that we have, so we can get a false negative. So I'm just mindful of the timing in which I provide oral prednisone to patients if I really have a high index of suspicion that that's what's going on, because it will help me determine, yes, I'm right, or no, there's something else. Also, I think for patients where I think that there may be a vasculitic component to their type 1 disease, I will go ahead and send an ANCA. I'll send things to look at ANA. I will try and do the initial panels to try and differentiate that there's something going on that we need to kind of respond to a rheumatologist with. And so those are part of the things that you think of common things first. Is this just a recurrent acute? Is this a bad mucosal disease because a patient was negligent in medical therapy or treatment of their infections, and now we have to do something to improve their airway? And when those things don't seem to fit right, then I'm going on to, is this an immunodeficiency? Is this person have a vasculitis? And a panel will help us take care of it, even though it's not a perfect science, because certainly we know there can be something called limited GPA, where it's primarily focused in the nose, and a large number of those actually do not have a positive ANCA.
Yeah, and if I could just add to that, Angela, the really good points. And you diagnose EGPA with looking for vasculitis and skin lesions, sometimes ANCA testing. But I think the summary that is again, harking back to the subtyping chapter, the figures 1 and 2 really go through some of the tests that are critical to diagnosing eosinophilic versus non-eosinophilic. But Drs. Mehta and Wise, in their chapter on eosinophilic inflammation, have done a really good job of presenting all eosinophilic conditions in there. And then Professor Lund and John Rimmer have done a really nice job of why in their chapter in table 1 on why it's so important to have a high index of suspicion for these non-eosinophilic granulomatosis diseases, because they go through ups and downs, and it's important to catch them when the disease is flared up. And we know that, if you biopsy the nose, having the chances of a positive biopsy for Wegener's disease is 40% or less. So, and ANCA testing can be negative in localized Wegener's as well. So your point, Sujana, about the saddle nose, septal perforation, crusting, etc., having that clinical suspicion is well taken.
Thank you. So, Dr. Donaldson, let's move on to what we used to call Samter's triad. So we used to call asthma, chronic rhinosinusitis with nasal polyposis, and aspirin sensitivity Samter's triad. And now it's called AERD, or aspirin exacerbated respiratory disease, or non-steroidal anti-inflammatory exacerbated respiratory disease. I think we're trying very hard to name things so we can understand the pathophysiology rather than just remembering somebody's name. Although at some point I'm going to call something the Chandrasekhar something and make everybody pronounce my name properly and spell it properly. But that's just a dream state. So AERD affects over 1.5 million Americans. 15% of people who have nasal polyposis and asthma may not be aware of their sensitivity to aspirin or to nonsteroidal agents. So can you talk to us a bit about this entity?
Absolutely. Thank you for that question. I think a lot of this goes back to what we just were talking about, which is having a high index of suspicion. So there was a really nice synopsis of the actual prevalence of this with whether you have CRS with polyps versus CRS with polyps and asthma, and then whether that asthma is severe. And when you have a combination of CRS with nasal polyps and severe asthma, the likelihood that that patient actually has AERD can be up to 70%. And these patients come to see us typically rather than our pulmonology and asthma colleagues first. So it is incumbent on us to know about that condition. I think there are many parts of that can explain a little bit of that 15% where people are walking around without the true diagnosis. One is which we've had a change in just the use of aspirin. So we're seeing these patients in that age range of 30, 40, 50 years old. And what was once aspirin, you take a baby aspirin a day for your heart health. Now that recommendation has changed. And so we're seeing people who just have never been exposed to that particular medication. And therefore, they don't know when you ask them, do you have an aspirin sensitivity? I get a lot of patients, especially my 30 and 40-year-olds who say, well, I've never had aspirin. I've never taken it. And so one of those challenges for that 15% is just the near exposure. So then we have to ask other questions. We need to ask them things about whether or not they drink alcohol and whether or not they have any symptoms as it relates to alcohol. We know that there's been some really good evidence that shows that alcohol ingestion, whether that be respiratory, GI related, or rash or the like, any of those symptoms after consumption of alcohol, especially somewhere between 15 and 30 minutes afterwards, can be a trigger that patient actually has AERD. So there's other ways for us to increase our risk of our suspicion by asking them things around it. Have they ever had ibuprofen, Motrin, Excedrin, these more common things? Now, that's not a one-to-one. So just because you have a sensitivity to ibuprofen doesn't mean you have a sensitivity to aspirin, but it's an important question that we still ask because it's more relatable to patients. So really thinking about asthma, asking about the severity of their asthma will really be helpful in getting that diagnosis. I think the other challenge is that these incrementally kind of compound. So we start with some upper airway symptoms, but that usually precedes having the asthma related symptoms, which usually precedes a diagnosis of CRS with polyps. And so the fact that these things don't come on at the same time, patients may have been getting care for those individual symptoms and no one has put the three things together.
And is there a role for trying to desensitize to aspirin sensitivity in these patients?
Absolutely. Yeah. So there's a lot of patients that really would benefit. In our particular practice, once I have an increased level of suspicion that patient may have an aspirin sensitivity, which about 89 to 90% of folks, the clinical history is going to tell you that. But for those people who we don't exactly know if they have an actual sensitivity based on just lack of exposure or the like, then the aspirin challenge will essentially tell us that the patient truly does have an allergy to aspirin. And those patients, again, folks who've never taken an ibuprofen, never taken an aspirin, patients who are on medications with an inhibition to biologics or to leukotrienes, these patients who are on baseline daily baby aspirin, that has been a challenge. I've had some patients who are in their 70s and 80s, and they've always been on aspirin. So they feel like they don't have an aspirin intolerance because they've been on it for so long. Those are the cases in which an aspirin challenge would be helpful to better delineate the diagnosis. We also use a urine LTE4 at the Mayo Clinic as a way to help us increase our level of suspicion for folks with AERD.
Thank you. So, we've talked for this time I've been talking to three, top-notch sinus surgeons, rhinologists, and we haven't really touched much on surgery. So, David, Dr. Jang, can you talk to us about the role of sinus surgery? You mentioned that in some of these patients, they've had a whole, all sinuses open, and then the next CT scan is just full of disease. So when do you have the excellent outcome that Dr. Lal talked about earlier? How do you pick these patients and what kind of surgeries are correct to offer them?
Yeah, thanks for that question. I'll start by saying that I think there was a point in time where people were worried that biologics would eliminate the need for the vast majority of sinus surgery. But we've had biologics now for at least a few years, and I think it's become clear that sinus surgery still plays an important role in chronic sinusitis, as well as in concurrent lower airway disease. And so overall, the treatment for unified airway disease, we can consider it to be multimodal, and sinus surgery is just one aspect of that, in addition to a variety of different medications. So I do think that even with type 2 inflammation, as Dr. Lal had alluded to, doing a thorough surgery, meticulous surgery, combined with topical steroids, is able to control inflammation in many patients. So I'll start by saying that. And we know that even after surgery, even if we don't eliminate all of the inflammation, and we know that sinus surgery is not a cure, but even if there's still some persistent inflammation, patients experience significant improvement in sinonasal quality of life after surgery. And there's good evidence to show that. But the article I thought was really interesting because it highlights all the evidence that sinus surgery may actually improve lower airway disease as well. And this is across multiple outcomes, including subjective symptoms, frequency of pulmonary exacerbations, as well as pulmonary function testing. And that's the mechanism for that. Little unclear, but it's probably through surgery, we're able to reduce systemic inflammatory mediators. There's probably an element of reducing the amount of secretions that go from the upper airway down to the lower airway. So overall, I think that sinus surgery is still here to stay and still plays an important role.
Thank you. When you say sinus surgery, and I know that the article by Miglani, Brar, and Lal looked at endoscopic sinus surgery. Is there a role for balloons in these patients? And please pardon my ignorance.
Yeah, I think that when you ask about the role of the balloon, you'll probably get multiple different answers depending on who you ask. But I think most of us would agree that when you're looking at type 2 inflammation, which is what we typically think of when we think of unified airway, the role of the balloon is very limited.
So you're really talking about opening up the sinuses, removing the tissue. I'm sorry, Devyani, did you want to say?
Yeah, I would say that, David, you made a very moderate answer. I think that, there's uses for balloons, but probably polyps are not the area. Patients that undergo first-time proper operation have very low rates of revision for recurrence of polyps. And that requires cleaning out the ethmoidal corridors widely, proper enterostomies to the maxillary sinus that incorporate the natural ostium, wide sphenoid sunisotomies, complete dissection of the frontal sinus drainage pathway up and above and below the ostium. And we know now in the literature that you have to have about 6 millimeters of width to a sinus ostium for high volume nasal irrigants to penetrate. And I would argue that standard of care has shifted now, I would say, in favor of using nasal steroid treatment locally with high volume irrigations. This disease is not a disease of osteometal obstruction. So all we can do with balloons is put the patient at risk of harm and ourselves at risk of harm if we get into the wrong place without much benefit. So I would strongly suggest to the readers to read the article that is published and also the related references and the guidelines that are referred to from both the American Rhinologic Society as well as the European Rhinologic Society. Sorry, Sujana, but I think that this ship is now sailed to the point where we have to be very definitive in terms of what surgical principles we are utilizing in the care of these patients. Otherwise, they're better served by non-surgical treatments, which may work superior to balloons, such as biologics or just nasal steroid sprays.
No, I really appreciate it because I think, if all you have is a hammer, everything looks like a nail, right? But if, there's an armamentarium, and we've talked about, changing the environment. We've talked about, trying to wrestle the cat away from the owner. We've talked about, using medications, first line, second line, third line, and how that differs across countries. And then as we talk about surgeries, I think it's very, very important. There are definitely roles for balloons, but not in this disease. Right. And I think that is really very important. Angela, did you want to weigh in? I don't know what's happening in Florida. I never know what's happening in Florida.
Half the time, I don't know what's happening in Florida. No, I would agree. I think the focus of these chapters are really talking about the unified airway. And when we're talking about that, we are just highlighting TH2. And I think if you don't feel comfortable addressing the sinuses in their totality for true Th2 disease, then we have to do the right thing for the patient, which is not to balloon, to give it minimal space to get them the tide over, but really to allow them to have an opportunity to have surgery in a thorough and complete fashion so they have the best chance for success. I think sometimes we struggle, or people struggle with just the technique and comfort, and they rely on the balloon to give in hopes that medical therapy plus the original surgery, the more limited surgery, will do the job. And we just have not seen that to be the evidence. And so I think from my standpoint, when we're talking about the unified airway, we're talking about patients who have both an upper and lower respiratory or disease processing, we have to think about doing the right thing first, as Devyani said.
So thank you. This has been a wonderful discussion. I would like to wrap it up with a sort of a what's the future speed round. So there's an article that you guys included by Ahmad, Marino, and Luong, and that talks about urinary leukotriene E4 as a marker, about how the microbiome influences airway physiology, and about targeted therapeutics that include biologics, JK inhibitors, and synthetic peptides, and these are all beginning to show promise. Table 1 in that article is really comprehensive, and I recommend our listeners to go look at it. So what I'd like to ask each of you is, based on what we know now, how should we research and validate these concepts further for patients with recalcitrant sinus disease and unified airways disease? And I'm going to start with you, Devyani.
Oh, wonderful. So I think the future is bright because we are starting to understand so many dimensions to chronic rhinosinusitis. And as a byproduct, Sujana, your patients with recalcitrant eosinophilic otitis media may also benefit.
Thank you. I so appreciate the friendship.
But quite honestly, a large part of what we are learning is actually looking at, and smart researchers in chronic sinusitis look at the asthma literature to see where they are going. And it harks back to the whole concept of unified airway disease. Asthma is a life-threatening disease. Chronic rhinosinusitis has been treated as a quality of life disease, although it's a significant modifier for low respiratory disease that can impact morbidity and mortality. So looking into the asthma literature, I think is very helpful. Some of the biologics that have now been adopted into our practice were all trial in asthma, and there are significant asthma trials that are still going on. I think I would like to refer to another chapter in this edition, which is by Brar and Lal on genetics and epigenetics. And for those listeners that may not be familiar with the concept of epigenetics, epigenetics is basically the study of how our native genes are functioning or not functioning due to the influence of environment, diet, nutrition, etc. And what happens is there is not a genetic mutation that occurs in cystic fibrosis, but by the influence of the environment, our DNA can get methylated or acetylated, and it gets there are changes in what genes are expressed or overexpressed or not expressed. And that, I think, is what is happening with the influence of environment on the prevalence of sinusitis. I don't think our genetics have changed that much, but how we are dealing with the environment definitely has. So for me, that's an exciting personal goal that I'm investigating. And there are things that do actually target the methylation of genes. And that's one area that I'd like for us to focus further. And certainly there's an asthma trial that does show some benefits in reduction of methylation, which closes off certain inhibitory and regulatory genes. So that is an interest. And of interest to me is also the microbiome. And I think there are certain microbes that have influence. And without going into too many details, Staph aureus, we know that it may even have an etiopathogenic effect rather than being a bystander. We know that if we control staph in patients with Wegener's disease or GPA, that they have better outcomes. Pseudomonas is another disease modifier. And in women, actually, in high estrogen states, you can have a mucoid form of Pseudomonas that is very recalcitrant. And so it can be a disease modifier. We know that we control Pseudomonas better in CF patients do better. And and they do. And but there's a host of bacteria and fungi and viruses we haven't studied. And one of the studies I've been involved with looked at viral markers as well. And so there's a lot to research in there. And what is that initial interaction at the immune barrier, which is basically an intact and functional mucosa in your sinuses or in the airway that now has been insulted and injured, that precipitated that immune reaction and begat the whole, the gamut of changes. So starting from the immune pathway, the genetics, the RNA, the proteins, et cetera. And each of these has a targeted diagnostic and therapeutic associated. So sorry, I kind of hogged that paragraph.
That's okay. We don't mind. Angela, what's in your crystal ball? What's in your wish list for what we learn and how we study it?
Yeah. For me, it's precision medicine. I think one of the things that we may not have talked too much about is the fact that these medications, whether it's surgery, whether it's maintenance medical therapy or biologics, are expensive, and they require some form of patient compliance in their duration. I always tell patients that sinus disease is a chronic condition. That's why we chose the word chronic when we described it. And so we as physicians also have to be mindful of the type of medicines that we're using and the expense that happens. And so for me, I'm really interested in precision medicines, identifying how do we de-escalate some of these medications that we're using. Biologics have really changed the game in our recalcitrant disease process. But the question that every patient gives us is, well, how long do I need to stay on it? And the answer that we have to give at this point is we don't know. The same thing with aspirin desensitization. These patients are on high doses of aspirin after their initial challenge for patients with AERD. But at this point, we don't really know what is a safe way to de-escalate them where we're still going to have a well-controlled pulmonary function as well as well-controlled sinus disease. And so my real interest is identifying biomarkers that will allow us to de-escalate in a timely fashion where we can then give precision medicine and focus on the economics of our condition as well.
Thank you. And now I'm going to go to David. So Dr. Jang, what is your view for where the research needs to go and what we need to learn?
Well, as Dr. Donaldson had stated, I think that more refined endotyping is going to be really important. So not just characterizing type 1 and type 3 inflammation, but the different types of type 2 inflammation, if I could say that. I think not all type 2 inflammation is the same. And so, finding out who would respond to a certain biologic is important. I also really thought that the last part of that chapter was interesting, where it was talking about therapeutic peptides for airway inflammation. We can kind of see something analogous to that in migraine treatment. We had a whole set of monoclonal antibodies, biologics, being used to treat migraine. And now the focus is more on small molecules that also, block really specific targets. And so I feel like that may serve as a really nice alternative, hopefully more cost effective in controlling airway inflammation.
Thank you. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. You can find all the issues, articles, and podcasts at www.oto.theclinics.com. I hope that your institutional library and even your personal library has a subscription to the issues, and you can get the podcast wherever you get your podcasts. Today, I've been speaking with the guest editors of the February 2023 issue, which is on unified airway disease. I've been speaking with Drs. Devyani Lal, Angela Donaldson, and David Jang. Dr. Lal is professor of otolaryngology and consultant in otolaryngology head and neck surgery, chair of the Division of Rhinology, and dean of education at the Mayo Clinic in Phoenix, Arizona. Dr. Donaldson is assistant professor and vice chair of research in the Department of Otolaryngology Head and Neck Surgery at the Mayo Clinic in Jacksonville, Florida. And Dr. Jang is associate professor in the Division of Rhinology and endoscopic skull-base surgery and in the Rhinology Clinical Research Program in the Department of Head and Neck Surgery and Communication Sciences at Duke University in Durham, North Carolina. Thank you all for putting together such a meaningful issue of clinics and for spending this time with me and with our listeners. I've really had a lot of fun.
Thanks for having us.
Thank you.
Thank you, Sujana.